All right. What we'll speak about now is the clinical significance of the respiratory volumes and then how that functions in terms of airflow. So we'll speak about the lung volumes and then the lung capacities and how we can use this information to talk about the efficiency of the lung. How well are the lungs functioning? And this is called the pulmonary function test. And that is probably the most important clinical test that we can use in order to tell us about the lungs function. Okay. Someone's saying, can COPD improve at all if someone quits smoking? Not likely. It's very hard to reverse. I don't think there's any cure or any type of treatment for it. It's usually just supplementing these patients with oxygen. So they're usually on lifelong oxygen supplementation, but there's no known cure or no known reversal. There's just therapeutic sort of improving the quality of life, if that makes sense, okay? Yeah. And this takes a really long time to occur. It takes a really long time. That's why it's usually 2 years or more of smoking. So someone who's smoking for a year is not going to have COPD. Someone who's having that chronic cough, so chronic cough is usually the first set of symptoms that we see, that's usually not COPD. It's usually a cough that's lasting more than 2 years is where we start to get worried or concerned about COPD. Okay, really good questions. Again, if you got more questions, please feel free to put them in the chat, okay? So what we'll speak about now is the spirometer, and the spirometer is the apparatus that we use to record what's called the spirometry readings. Okay, so spirometer is the apparatus and spirometry is the process of actually acquiring these readings. And what these readings are basically the lung volumes. So the amount of air that we can move in and out of the lungs can be recorded, some of those volumes, not all, and I'll talk about which ones cannot be acquired using spirometry. But basically we can have a patient blow into this apparatus. It's going to manipulate the amount of air that's coming in. Obviously, they blow air into this tube here, and then that is going to change the water level, right, in the container that's surrounding this central apparatus, and then that can be transcribed onto this sheet of paper using this kind of scribe-like part of the apparatus here, okay? And then that will tell us how much volume, right, how much air is being moved in and out of the lungs, and then we can use those volumes to then look at how well the lung is functioning, okay? Not just the volume in terms of the amount, but also the rate, how fast we can move that air in and out, and we'll talk about some of those rates a little bit later on. Now, I do want to point out that this apparatus is very old, so if you're working in a clinical setting, you're not going to see this. You're going to see something more like this, and I've included a little bit of a snippet of a picture here in the upper left corner. And so it's all computerized these days. The readings are all digital these days, so you're not going to see something like this if you're working in a clinical setting. But this just shows us kind of where we were and where we are now, like how far we've come between this large, bulky apparatus with a pen and water and air to a more computerized apparatus with this digital sort of simplified reading. Okay, but it's the same idea, it's the same principle. It's going to tell us how much volume is moving in and out by blowing into this tube, and it's going to also tell us the rate, how fast we can do that, and that is going to be an important part of deducing our pulmonary function. Okay. So the lung volumes and lung capacities are basically two different things. So the volumes are the amount of air or the volume of air that we can record from the spirometry readings. So basically we can deduce the lung volumes directly. We can measure those directly. The capacities are what we use in terms of putting two or more volumes together, okay? So for example, the total lung capacity is really a combination of all of our lung volumes, the tidal volume, the inspiratory reserve volume, the expiratory reserve volume, and then the residual volume. So our capacities can be deduced by basically putting several volumes together, whereas our volumes can be immediately recorded from the spirometer, from that spirometry reading, okay? And so let's talk about these volumes here individually, and then we'll talk about the capacities a little bit later on. So basically we've got our tidal volume. And so this is a single unforced breath. So I usually like to encourage students to actually do this breathing on yourself as a way to really get a sense of what these volumes are. So if you're sitting quietly at rest and you take a nice quiet breath in and a nice quiet breath out, that is your tidal volume. Okay, it's a single unforced breath, no additional effort, no additional exertion, and that is usually about 500 milliliters. Okay. Our inspiratory reserve volume, or IRV, is the amount of air that we can breathe in on top of our tidal volume. So again, if you're sitting quietly, you breathe air in quietly. How much more air can you inspire on top of that quiet breath? Right, that's going to really cause you to really engage your diaphragm, really engage your external intercostals, and you should actually be able to feel that as you bring additional air in on top of your tidal volume. That's usually about 3,000 milliliters, and that is your IRV, or your inspiratory reserve volume. And then we've got the expiratory reserve volume, so kind of a similar idea, but in the opposite direction. So if you take a nice quiet breath in and then out, how much air can you force out on top of your tidal volume? So after you've taken your quiet breath out, how much additional air can you force out? And again, that's really going to call on you engaging your abdominal muscles as well as your internal intercostals as a part of that forced expiration. Okay, so that's usually about 1,000 milliliters, and that is the amount of air that you can move out on top of a quiet breath out. And then finally, we've got the residual volume, about 1,200 milliliters. That is the volume of air left in your lungs after your expiratory reserve. So after you take a nice big deep breath in and then a nice big deep breath out, so forcing all of the air that you can possibly force out of your lungs, there's still some air left over. That is called your residual volume. And that is different from your functional residual capacity. Okay, we talked about functional residual capacity before, but functional residual capacity is actually a combination of both of these volumes. Okay, and we'll talk about this coming up as well, but I don't want you to confuse residual volume with functional residual capacity. So this is not measured directly, so we cannot directly measure the residual volume simply because it's what's left in your lungs after you've taken your maximum forced expiration. And so the way that we usually measure residual volume is by using the helium dilution method, which is a very fancy technique that uses a known quantity of helium in a known amount of air. And they actually have the patients inhale that helium and then exhale that helium. And then using a fancy equation, they calculate the difference, and then they can determine or deduce how much air was left inside your lung based upon how it interacted with that known quantity of helium. Okay. All right, so from our lung volumes, we can then put some of those volumes together and we can deduce our capacities. So capacities cannot be measured directly, right? The volumes can be measured directly, but then the capacities are basically combining two or more lung volumes. So the first one is the inspiratory capacity. And this is a combination of your tidal volume, so your normal quiet breath in and out, as well as your inspiratory reserve volume, so that maximum air that you can bring in on top of your tidal volume. And that is usually about 3,500 milliliters. Then we have your vital capacity. Your vital capacity is the maximum air that can be expired after your maximum inspiration. And so basically, if you take the deepest breath that you can in and the deepest breath that you can out, that is your vital capacity. It's usually about 4,500 milliliters. And so in order to find this, we simply add your tidal volume, right, your quiet in and out respiration, your inspiratory reserve, which is your maximum air inspired, as well as your expiratory reserve, which is your maximum air expired. So if you take the biggest breath that you can in, and then you take the biggest breath that you can out, all of that constitutes your vital capacity. The third capacity here is the functional residual capacity, or FRC. This is the amount of air that's left in your lungs after a resting tidal volume. So after you take a quiet breath in and then a quiet breath out, whatever is left inside your lungs is your functional residual capacity. And that is actually a combination of two of your volumes, right? One is your expiratory reserve volume, the amount of air that you would have been able to force out if you tried. And then the second volume is your residual volume, the amount of air that you cannot get out even if you try. That's always left back in your lungs. That is your residual volume, okay? So if you combine your forced volume, which is your expiratory reserve volume, with your residual volume, which is what's always left back in the lungs, that is your functional residual capacity. And that is about 2,200 milliliters. And we talked about this at the beginning of class as being really important for creating the pressure gradients that's needed to move air in and out, okay? The fact that we do have some air left in the lungs that can help facilitate that gradient. And then the total lung capacity is kind of all of those volumes combined. It's the total amount of air in and out of the lung, well, not out, but inside the lungs, if you take the biggest breath that you can in. So it's going to include your vital capacity, which is your tidal volume, inspiratory reserve, and expiratory reserve. So remember, all of this is vital capacity plus your residual volume, right? And that is going to be your total lung capacity. That is about 5,700 milliliters. And that is the maximum amount of air in your lungs if you take the biggest, deepest breath that you can in. And that is probably one of the most important lung capacities in terms of lung function.